Will request Dr. Sushil Patkar next.
No, he's unable to join us for some reason today.
Okay.
So we move on to the last talk, which is on management of CV junction anomalies in children below 8 years by Dr. Chandan Mohanty.
Good evening, everyone. I would like to thank the committee of NSSA for this opportunity to discuss about bony craniovertebral junction diseases in children less than 8 years. This is somewhat of a topic which hasn't been studied in much detail. So I would briefly present my experience and then discuss what the literature says about this. So we know that CVJ diseases present a unique challenge because most of the flexion, extension, and axial rotation occurs at the CVJ, and it also accommodates the key vascular as well as the neural structures. Understanding the embryology of CVJ is extremely important to understand the management of the pediatric craniovertebral junction pathology. Simplistically talking, the basion as well as the ophisthion is formed by the proatlas. The somite number 4, 5, 6 contribute to the formation of the C1, and somite number 5, 6, 7 contribute to the formation of C7. Knowing the exact age of ossification of the various centers is important. C1 develops from 3 ossification centers, and C2 develops from 5 ossification centers, which eventually most of the fusion in C1, C2 happens by the age of 7 to 10 years. As far as bony pediatric CVJ anomalies are concerned, the main considerations are the small osseous structures, incomplete ossification, lax ligamentous structures, presence of syndromic anomalies, different injury patterns, increased complication rate associated with external immobilization, especially halo, and even for that matter, use of something like Philadelphia collar. We do not have implants which are specific for pediatric CVJ anomalies. I think that is one of the biggest challenge, and that I would show it in my presentation further. So with this, we wanted to discuss the presentation of CVJ diseases in children less than 8 years and their subsequent management. So a retrospective chart review was performed from 2015 to 2019, and we analyzed the clinical, the radiological, and the surgical data and outcomes in detail. So we had a total of 87 CVJ patients, out of which 18 patients fulfilled the criteria of being less than 8 years, and these patients were subsequently analyzed. So our follow-up duration is about 14 to 62 months, with a mean follow-up of about 2.5 years. The youngest patient that we have operated is a 14-month-old boy. Transarticular C1, C2 fixation is something which I prefer and has been performed in about 1/3 of my cases. Occipital C1, C2 fixation is something which we do when our placement of the C1, C2 transarticular screws is not safe and C1 lateral mass is not big enough to accommodate the screws. C2 translaminar screw is is the fixation point of choice for me as far as pediatric CVJ is concerned. Fortunately, we have been lucky not to have major complications. Only one patient with a neurological deterioration following surgery, which recovered over a period of his post-op stay. Most of our patients made at least 1 grade improvement in power following surgery. So we'll go to some case illustrations. This is case number 1. This is a 4-year-old boy who presented with painful neck movements and had a fall from chair, a trivial trauma 15 days back. The child did not have any neurological deficits, but his neck movements were extremely painful, and he used to hold his head with both his hands just to avoid any movements of his neck. And this is the CT and the MRI of this boy that showed a pathological fracture of the C2, mainly the C2 body, along with a prevertebral collection which extended almost up to the level of C3. Interestingly, the C2, C3 disc space is completely intact. On flexion extension X-rays, we see that the atlantoaxial instability is worsened, especially on flexion. So with this, with the possibility of a pathological fracture, we did a PET scan for this boy, and that showed a hypermetabolic spot both in the scapula as well as the C2. The hypermetabolic spot in the scapula was biopsied, and this showed to be a Langerhans cell histiocytosis, which is only the second case in literature of a Langerhans cell histiocytosis in the atlantoaxial junction, which caused instability. So this child underwent a C1, C2 transarticular screw fixation and a modified Sontag technique of C1, C2 interspinous fixation. As you can see, there was good fusion and the C2 has completely reformed following this. So we have a 2-year follow-up on this boy. This is an 8-year-old girl who had presented with restricted neck movements of 4 to 5 months, progressive spastic quadriparesis with torticollis on examination. So this is her X-ray and MRI. As you can see, she has a severe rotatory sublux, rotatory AAD causing severe cord compression. The right side facets are completely dislocated. You can see the right C2 facet is completely posterior to the right C1 facet, with the joint angulation being almost vertical to each other. So this patient again underwent a placement of intra-op traction, and we could place a C1, C2 transarticular screw safely, and this girl is doing well at 18-month follow-up. Again, we have this youngest kid in our series, who's a 14-year-old boy who presented with loss of motor milestones of 2 months duration, inability to sit and stand without support, unable to grasp objects. An examination had prominence of all the accessory muscles of respiration. He had increased effort of breathing with decreased tone in all the 4 limbs, with power barely being anti-gravity. So this is his MRI, which showed atlantoaxial dislocation with C1 arch stenosis, with cord signal changes seen at the level of the cervicomedullary junction. Vertebral artery angiography is something which we do routinely, and this patient showed a dominant left vertebral artery compared to the right side. The C1 lateral mass was very small in size, which was only 8 mm in length and 2.8 mm in breadth. And for this reason, the patient underwent an occipital C2 fixation. Since the right vertebral artery was non-dominant, we used a right bar screw on the C2, and on the left side, we used a C2 translaminar screw since the vertebral artery was dominant. You can see the bone grafts wedged between occiput and C2 just under the rods on both the sides here. So this is the post-op CT of this patient. The child recovered partially and is currently able to walk with support at 1.5 years of follow-up. So another important point that I want to show in this post-op CT is the fact that you see the occipital screw, which is prominent and kind of protruding into the posterior fossa. The simple reason being that the thickness of the occipital heel in this child was only about 3 mm, whereas the smallest occipital screw, cortical screw that we get in the market is 6 mm. So there's always this struggle to get an implant which is suitable for kids, especially who are less than 5 years of age. This is another very interesting case. A 7-year-old girl who had gait instability and frequent falls in school while she was playing, and she started swaying to the left while walking. This was about a 4-month history. On examination, she had a spastic gait with power of 4/5, and she was hyperreflexic in all the 4 limbs. So this patient interestingly had a unilateral hypertrophy of the C1 lateral mass with the rotatory AAD, with Chiari malformation and C1 arch assimilation. So flexion extension X-rays were done, and you can see that there's no atlantoaxial dislocation. The dens and anterior tubercle of C1 pretty much move together, both in flexion as well as in extension. So we went back to the basics, as we were not sure as to how we were going to treat this, because drilling the hypertrophic facet was going to be difficult. If you remember the law of Steele's, we know that 1/3 of the canal at the CVJ is occupied by the odontoid, 1/3 is occupied by the cord, and 1/3 is free space. For this kid, we can see that the Chiari malformation also contributes significantly in causing cord compression. And if you remember our anatomy, the position of the hypertrophic facet is actually the attachment of the transverse atlantal ligament, and trying to drill this off would actually cause an iatrogenic atlantoaxial dislocation. So we did something somewhat controversial for this patient. We just did a foramen magnum decompression, C1 arch excision, tonsillar resection, and uroplasty. So the tonsillar resection allowed us, by following the Steele's rule, to make adequate space. We have now a 16-month follow-up for this patient. We see that her atlantoaxial dislocation has not worsened. The hypertrophic facet is still there as expected. However, neurologically, she has made a complete recovery. This patient is obviously someone which we are watching with keen interest, because if at all there would be any instability, something which she was counseled about once she grows up. So we'll keep a close eye on this patient. So what are the limitations of our study is that we do not have long-term data. We have data only starting from 14 months to about 5 years. We have not followed these kids through their growth spurt, which is important, I feel, when we are operating kids under the age of 5 years. We had relatively fewer syndromic patients. We are only 4, 2 of them being achondroplastics and 2 of them with Down syndrome. Interestingly, there are only 2 papers in literature which concentrate on the role of rigid fixation in pediatric craniovertebral junction anomalies. Both of these papers are from the Texas Children's Hospital. They have seen that the size of the lateral mass is about 15 mm in the C1, with a mediolateral width being about 7 mm. The C2 pedicle is more than 3.5 mm with a length of more than 17 mm. And the transarticular screws were safe in only 4% of their patient population. There is no data from Indian population. We do not have any age-wise stratification for pediatric CVJ. Implant failure, fortunately, was rare both in our series as well as the series from the Texas Children's Hospital. So the take-home message is we do not have specialized pediatric CVJ instrumentation. Hence, to study the CT carefully to decide the screw size is the first step. We also need to make sure that we attain a good screw position in our first attempt, since the margin of error is quite low because of the small size of the bones. CT angio is something that which we do for every case to look for the growth of the vertebral artery. My personal preference is to use the C1, C2 transarticular screws, since they have the least implant density, hence the least cost, and have excellent stability. Point of fixation which I prefer in C2 is the translaminar screws, and second choice is the pedicle or the bar screw. C1 screws can be difficult in anomalous vertebral arteries or very young children, where even blood loss of 50 to 80 ml in a short time can be problematic. Children also have small C1 lateral mass, from what we have seen in our series in comparison to what has been said in literature. We prefer to preserve the C2 root to avoid troublesome occipital sores. Customizable collar is often used by us following instrumentation, and we prefer to use rib or local grafts. We avoid a one technique fits all approach for our patients. Thank you very much. I'll be happy to take any questions.
Thank you, Dr. Mohanty. I think it is one of situation when you come across, children with atlantoaxial dislocation, and whenever you come across them, then you are struck with the questions, which I think you have answered very well in your talk. Are there any questions? Okay, so I don't see any questions coming up from anywhere. Yeah, that's the last talk of the session and last talk of the day. So, sir, you want to ask something?
No.
Dr. Pathak?
No.
Okay. So,
no, thank you. That was a good talk.
Thank you, sir.
Thank you.
So, thank you all for joining us and have a great evening. Thank you.
Good
Thank you very
evening,
much.
organizing committee here. I thank all the delegates
the chairpersons, moderators, and speakers for the excellent talk and moderation. We have finished everything in time today. And I'd like to say that the Odisha Medical Council has accredited 8-10 hours of semi-accreditation for this program. They have verbally given and they give in writing for this semi program. This NSSA Spine 20 November. And for tomorrow, we have 8 o'clock in Hall B and 9 o'clock in Hall A. And there will be the general body meeting between 12 to 1, followed by lunch, and the validatory function will be at 4 to 4:30. That will be program for tomorrow. I hope that all of you should again join tomorrow and attend all the scientific sessions as well as general body meeting and validatory function. Thank you very much. Thank you once again for all of you. Thank you.
Thank you for giving us this opportunity. It's a great meet and
Right.
very well done. And we pay our regards to Dr. Ramani also and giving the blessings.